Dear friends, colleagues, the scientific chair and the organizers of KOGS Central, first of all, I'm privileged and thank you to be invited for this prestigious conference. I would like to speak on ovulation induction in IUI, as well as I'll touch upon the procedure and complications of IUI. So first of all, before we go to the ovulation induction, it is very important to check the ovarian reserve of the patient, which is very important to decide about the dose of what we are going to start and how much dose and how we are going to proceed. And we all know there is a decline in the woman's ovarian reserve. Every woman is born with certain set of eggs which go on decreasing as the woman ages. So it is especially important to check the ovarian reserve, especially in the women who are over 30 years of age, who have history of exposure to confirmed gonadotoxin like chemotherapy, tobacco, smoking or radiation therapy. If someone has a strong family history of early menopause or premature ovarian failure, and women who have had extensive surgeries on the ovaries like endometriosis, any cyst or anything like that, which can obviously take away the antral follicles. And if we classify the ovarian reserve markers, I'll just outline. So the clinical markers are the most important, which includes age and the menstrual pattern. There are endocrine static markers which can also give us a clue about the ovarian reserve, like FSH, E2, inhibin and serum AMH, out of which we mostly rely on the anti-Mullerian hormone. Then there are endocrine dynamic tests like CCT, GAST and effort, which are not practiced nowadays, so we won't touch upon that. Then we have ultrasound markers in which the antral follicle count in the ovaries, the ovarian volume and the ovarian vascularity should be seen. So out of all these, practically if we see in clinical practice, it is the AMH and the antral follicle count which is the most important, and the clinicians can rely upon that. Now, before I go on to the ovulation induction, let's understand first the basic physiology. So, at the beginning of cycle, you can see when a woman is menstruating, the endometrium would be thinner, and the FSH levels, the FSH, LH, and E2, everything baseline would be at the lower level. And as the cycle progresses, starting from say day 3 or day 4, the FSH levels start rising, and the antral follicles which are already selected in the ovary, one of the follicles will respond to the FSH threshold and it will get selected and it will start growing. And as the follicle will be selected, you can see the E2 levels start rising in response to the growing follicle. And we say that once the follicle is mature, the peak E2 levels should be at least between 150 to 200 when the LH surge will happen and the follicle will come out, the egg will come out of the follicle. So that is how the ovulation happens, and you can simultaneously see the changes in the endometrium. The endometrium starts becoming thicker in response to the estrogen, and once the follicle is released in the second half, now it is the progesterone which will be released by the corpus luteum. So first half is estrogen and the second half is progesterone, and there is a peak progesterone levels which we say are important to sustain the pregnancy. So now with this background, let's go to the ovulation induction. And why do we need ovulation induction? Because every month a woman is producing one egg, but it has been seen in most of the studies that if IUI is performed with controlled ovarian hyperstimulation, there is tripling of pregnancy rates rather than just doing without controlled ovarian hyperstimulation. So the rationale behind the stimulation is that we want to have more eggs, say 2-3 eggs in one cycle, so that there is a better chance of the tubal pickup of at least one egg out of those 2-3. And also when we give the patient ovulatory medications, there is a subtle correction in the ovulatory dysfunction. And it is also seen that stimulation with HMG or FSH have additional benefit of enhanced oocyte quality and better endometrial implantation. So the common protocols used for IUI are clomiphene citrate, letrozole and gonadotropins. In clomiphene, we normally start from day 2 or day 3 for 5 days. You can start with 100 milligram in a normal ovulating patients, but in PCO patients it is advisable to start with 50 milligrams daily. Similarly, letrozole, you can start from day 2 to day 5, from 2.5 milligrams daily for 5 days. And gonadotropins, we usually don't go beyond 150 if we are doing it for IUI. So normally what we do is, nowadays, I'll come to the mechanism of action of clomiphene and letrozole. And nowadays letrozole is the preferred drug. So we start the letroz from day 2, and along with that we add the HMG 75 IU for 5 days. And in PCO patients, if you see the LH levels are high, say they are more than 7, 8 or 10, then you can take them on FSH, because FSH is expensive, so we prefer using HMG. So after 5 days of injections and tablets, you do the transvaginal scan and see the follicular size. If it is about 12, 13, 14, you can give her 2 more doses and repeat the scan on day 10 or 11. And once the follicle reaches 18 to 20 millimeter size, we trigger with Ovitrel 250 micrograms, which is given subcutaneous. You can even use HCG, but the only issue with HCG is that the cold storage should be maintained properly. Otherwise, this is a trigger injection, and it's very important for the release of the egg. And if we look at the recent data, the IUI is done like in our center also. We are shifting towards little later, beyond 36 hours, and we usually perform IUI at 40 hours. So you can give the trigger, say around 8 o'clock in the night. So from 8 to 8 next day it will be 24 hours, and next day 8 it will be 36 hours, and you add another 4 hours. So around 12 or 1 p.m. you can schedule your IUIs. Why we are doing like this nowadays is that it is said that once the follicle is released at 36 hours, it takes another 3-4 hours for the follicle to be picked up and to travel inside the tube when it is fertilizable. So the results have been better, and that's why we are doing the IUI at 40 hours now. And ideally we say the number of follicles when you are stimulating the patient for IUI should be less than 3. Otherwise the chances of multiple pregnancy are higher. And how can you document ovulation? So out of this, all these methods, the basal body temperature, ultrasound, LH detection, or mid-luteal serum progesterone, ultrasound follicle monitoring is the best, which is easily available. And it is always better to do your scans yourself, so that you can correlate what is happening with the ovaries and the follicle and the ovulation. So this is what happens in a natural cycle. If you look at it, as I told you in the physiology, as the FSH starts rising, one of the antral follicles which is most responsive to the FSH threshold will get selected, and the E2 levels start rising. And once the E2 levels is at peak, the LH surge will happen and ovulation will happen. Now looking at the clomiphene citrate mechanism of action, it has a structure similar to estrogen. So it binds to the estrogen receptors throughout the body. It's not only in the pituitary or the peripheral areas, but also the endometrium, cervix, etc. So it binds to all the estrogen receptors, and so there is depletion of the receptors, and the pituitary thinks that now the E2 levels are falling, and so it will start secreting more FSH, and that is why there is a increased follicular growth, maturation and ovulation. So you can see here, this is what happens in a clomiphene cycle. Because the FSH levels are rising in spite of the dominant follicle being selected, there are more follicles which are selected, and that's why you have 3 or 4 follicles which ovulate when we give the clomiphene citrate. So you can give the clomiphene as a single agent, and you can increase the dose up to 250. Some of the resistant PCOS do not respond to even 200 or 250. And in PCOS, it is always advisable to combine it with metformin and gonadotropins if you are not able to induce ovulation. And if there are 2 or 3 follicles, obviously the E2 levels will rise faster to cause LH surge, and we don't want the premature LH surge. So you can add antagonist when the follicle size is say 14-15 to prevent the LH surge, because we don't want immature oocyte to be released, then obviously you won't get pregnancy. In resistant cases of PCOS, you can try adding dexamethasone 0.5 mg daily. That can sometimes correct the immunological factors, and you can have a follicle. This is something which we used to practice in India, and it is basically for the patients. Some of the patients are not able to afford HMGs, so it's a cheaper option which is extended clomiphene regimen. So you can go on giving the clomiphene for 10 days, and you might get some follicles for the patients, especially who can't afford the gonadotropins. Antagonist, I have already told you. Once you start the patient on antagonist, which is cetrorelix is easily available here. So it is given subcutaneous 0.25 mg, but the only precaution that you have to take is that the effect lasts only 24 hours. So if it is given at 6 p.m., it has to be given at 6 p.m. the next day or before, but not later. So it eliminates the risk of LH surge completely, and you can even sometimes, if the follicles are ready on Friday, you can put the patient on cetrorelix, you can give on Saturday, and you can trigger on Saturday so that the IUI falls on Monday. So it is quite commonly practiced in Europe countries like this. But in spite of all this, if you see with clomiphene citrate, the ovulation rates are 60 to 80%, but the pregnancy rates per cycle are only 10 to 20%. Why they are so low in spite of having higher ovulation rates is because of the anti-estrogenic side effects, and the half-life is longer. So because it goes and blocks the estrogen receptors in the endometrium also, as well as in the cervix, so the endometrial thickness is not very good, and the cervical mucus also gets affected, and that is why it is not giving very good pregnancy results. Now, why we say that we are preferring letrozole nowadays? Because it doesn't have the anti-estrogenic side effects like clomiphene. So if you look at 2-cell 2-gonadotropin theory, the pituitary LH acts on theca interna, and it converts androgens into estrogens through the aromatase enzyme activity. Now what letrozole does is, letrozole is a aromatase enzyme inhibitor. It will not let the androgen get converted into estrogen, so the estrogen levels will start falling, and again the pituitary will think that now the E2 levels are following, so it will start secreting more FSH, and you will have more follicles. But the advantage here is the half-life of letrozole is very short. It's only 30 to 60 hours. So as soon as the dominant follicle is selected, within next 2 days the letrozole effect is gone, and once the follicle starts rising, then the E2 will start coming in, the pituitary will come back to the normal, and you will have a good endometrium. as compared to the clomiphene. So there is total suppression of estrogen levels, and it is maximum by day 5 and 7. And because the half-life is shorter, as the follicle will grow, the smaller follicle will undergo atresia, and you have monofollicular ovulation and a better endometrium. So this is what happens in a letrozole cycle. And it is also said that it also has a peripheral action by increasing the follicular sensitivity to FSH, and also it increases there is upregulation of the endometrial receptors. So the blood flow and everything is better, and that's why the pregnancy rates are better with the letrozole. Contraindications for both Clomid and letrozole: any suspected or known hypersensitivity, or any hepatic or renal insufficiency. And of course, in pregnancy and lactation, it's not advisable. Letrose we prefer giving 2.5 or at the most 5, not more than that. And it can again in PCO patients be combined with metformin, bromocriptine, and gonadotropins. So in IUI cycles, we usually combine letrozole with gonadotropins to have a better endometrium as well as monofollicular growth, because we don't want too many follicles. So if you compare letrozole with Clomid, you will see that the advantage with letrozole is that there is no downregulation of the receptors, there is no anti-estrogenic side effect, and because of the monofollicular ovulation, the multiple pregnancy rates are low, which is to the tune of only 4% as compared to Clomid, which is 22%, and the cervical mucus is better. So the points to remember before you start the ovulation is always do a day 2, day 3 scan to rule out hyperplastic endometrium. So on day 2 or day 3 scan, if your endometrium is more than 4 millimeter, always remember the endometrium is always in sync with the estrogen levels. So if it is more than 4-5 millimeters, then you can put the patient on progesterone for maybe 2 or 3 cycles, like medroxyprogesterone 20 milligrams every day for 21 days, and then check after 2 cycles. And still, if the endometrium remains thick, then the patient should be taken up for hysteroscopy DNC and send the tissue for hyperplasia. Because if the endometrium is hyperplastic, it is difficult to get the pregnancy. Day 2 serum estradiol levels, again up to 50-60 we take as normal, but if they are more, it means there is already a premature selection of the follicles. If you start with the high E2 levels and you put the patient on ovulation induction, then already suppose E2 levels are at say 90 or 100, so within next 4-5 days it will reach the peak and it will cause LH surge, and you will have a premature follicle. So similarly, the LH levels, if they are higher, again the oocyte quality can be compromised and the endometrium can have premature progesterone effect. Again, you put the patient on OCP for 2-3 cycles, combine metformin, change to GnRH agonist to get down the LH levels, and ovarian drilling should be the last option, which we are seeing nowadays. People are doing a lot, but it can reduce the antral follicles. So that's that's our center, and I practice in Westlands, and we are the only ones to have the IMF matcher barcoding system in our center to prevent any lab errors. So this is the center, and I have written a lot of chapters in many books, and this is the recent one, ovarian stimulation protocols for the practicing gynecologist. I'll take very shortly the procedure and the complications of IUI, just some important points, just a few points. So there are different types of inseminations. One is the vaginal insemination, intracervical insemination, and intrauterine. So intrauterine is the one which we are practicing mostly. And regarding the timing of IUI, I have told you we normally do when we are giving the HCG. there is something about single and double IUI. The double IUI is preferable only in those patients where the sperm counts are lower, say between 5 to 10, and the patient is not willing for IVF. So in those cases, double IUI can be done. So we say the first IUI should be done at 24 hours and the second one at 40 to 42 hours after the HCG. And the single one we usually time at 40 to 42 hours for the reasons I have already discussed in the previous lecture. The position has to be lithotomy. The key points during insemination is you should have a separate room, take a proper consent. The sample labeling is very important if there are 2-3 patients going on. And you should use the powder-free gloves. Always use only normal saline, no betadine, because it is toxic to the gametes. And we prefer using the Cusco speculum. And catheter can be either soft or firm, whichever you are comfortable with. And always fill the syringe with the attached syringe. And there should be a dead space of about 0.5 ml in the syringe to push the whole semen, otherwise some of the semen will remain in the catheter. So there should always be some dead space to push that inside the whole volume. And we say normally the semen should be deposited about 6 centimeter from the uterine cavity. It should be about 1.5 centimeter below the fundus. So that's how the procedure is done. I'm sure you all are doing it. Post insemination, we usually put the patient on progesterone support and also HCG 5000 IU on day 0, day 2 and day 5. Whenever you are giving HCG, it should be repeated at 3 days because the half-life of HCG is only 72 hours. If there is a difficult catheter insertion, then you should use the do with the full bladder so that the uterus is in the straight line. You can use antispasmodics. We also have a metal cannula in difficult cases, we use that. The complications of IUI, we all know there can be a lot of complications because of ovulation induction related to the insemination procedure, obstetric gynae complications. So because of the ovulation induction, of course, as I said, if there are more than 4 follicles, it's better to cancel rather than having multiple births. And the incidence is about 20%. And there can be ovarian hyperstimulation syndrome, especially in PCO patients, if you are not careful, even with 50 milligrams of Clomid. So one should be very, very careful about the ovulation induction. Insemination complications, there can be little pain, there can be infection if proper precautions are not taken during the insemination. Then there can be laboratory errors, there can be spillage, mixing, wrong labeling. So all these things need to be taken care of. In obstetric complications, there can be miscarriage, ectopic pregnancy, and people have a myth that there can be ovarian cancers because of multiple stimulations, but there is no convincing evidence of this. And of course, there can be psychological complications, especially in male subfertility. They can feel a little depressed that they are not able to have natural pregnancy. Thank you so much for your patient hearing. And if there's anyone, we have a IVF center. Anyone who wants to come and see and do cases are most welcome to come to our center in Nairobi. I would be very happy to help in any which way. My cards are there, my number is there. If you have any problem, stimulation or IUI or even doing IVFs, you're most welcome. Thank you.